Assalamu alaikum. I'm glad that there are quite a few participants on the net. The topic that we had chosen for today was that's in line with the area that we are discussing these days, which is based on scales, and because that's also is a requirement of the CPSP. So therefore, I thought that opening and closing abdomen, and when we talk about that, then we also need to have a little bit of knowledge about the anterior abdominal wall, where we would be giving person. So there will be a brief review of the anatomy of anterior abdominal wall, and then I'll talk a little bit about some of the incisions. Then later on we can in a subsequent session we can look at some of the instruments and how we proceed with that, and perhaps we'll be able to also make available some kind of demonstration about the incisions and what needs to be done in detail about them. Layers of the abdominal wall from outside going inwards are skin, superficial fascia, muscles, transversalis fascia, extraperitoneal fat, and peritoneum itself. These are the 6 layers. Mind you, when we open or close the abdomen, since we do most of our work in midline, and even in transverse incisions, we concentrate on midline. We separate the rectus muscle and approach the peritoneum through that, and give an incision in the peritoneum. But we do not really realize about the various layers which of muscles which come into form that rectus sheath in that area, and we do not identify those muscles. And also particularly, we do not really pay any attention to transversalis fascia, whether there is something like that or not, which is an important component of the abdominal wall. Particularly when we are closing the abdomen, we need to take that into account. And when we are stitching the peritoneum, it is a good practice to take a bite of transversalis fascia and also to approximate that over the peritoneum, not separate in a separate layer, but along with peritoneum, we can do that. Now, anterior abdominal wall muscles are external oblique, internal oblique, transversus abdominis, then rectus abdominis muscle, which is in the middle. These muscles, the 3 muscles that I just named, external, internal, and transversus, they start from the lateral and they converge they come over onto the middle of the abdomen. Pyramidalis is a small, insignificant muscle. As a matter of fact, the only surgical significance of pyramidalis is that it helps you identify where the midline is. And you must have seen that this muscle varies in size. Sometimes it is absolutely insignificant. You can't really identify that. And sometimes it is coming good about 3 inches up to the upwards in the abdomen. But it's a good practice to identify these and go according to that and keep the muscles in their line, and not to meddle too much or not to this particularly I'm saying in with regard to pyramidalis muscle, that it tends to be mistreated or maltreated, and in second or third cesarean, for example, if you are opening the abdomen at that time, sometimes it is half of it is attached to the rectus sheath and half is lying over there. So there is a little bit of the muscle which is there to be recognized. Anyway, these are the layers. We'll talk about that in further detail. The function of these muscles is to protect the internal abdominal organs, obviously providing them this protective cage, which is only muscular in front, and the stabilization and rotation of the trunk. these are the muscles which help act by their actions, internal, external, oblique, transverse also. And they also, particularly rectus abdominis muscle, in developing increased intra-abdominal pressure, which is required or which reflexly is there during coughing or passing stools or at the time of vomiting. Now, if you look at the muscles here, this is to demonstrate, and I would want you to concentrate on this part. This is the lateral aspect. You see, that's why this diagram will be discussed in two parts. One is lateral aspect and one is the medial aspect. In lateral aspect, of course, from going, I'll show you some other diagrams too. So skin, subcutaneous tissue, external oblique, and below that would be internal oblique, then transversus, and then fascia transversalis, and then peritoneum. And if we look at the medial aspect, then there is skin, superficial fascia, anterior wall of rectus sheath, which has been taken away at this point, rectus muscle, which is in the medial part only, and posterior wall of rectus sheath and peritoneum. Now, posterior wall of rectus sheath also ends about in an inch and a half below umbilicus. Above that, up to the costal margin and xiphisternum, there is posterior rectus sheath, anterior rectus sheath, and posterior rectus sheath. But below the umbilicus, it is present only in about 1.5 inch, and then there is no posterior sheath, as all the components of the three muscles, that is external, internal obliques, and transversalis, they merge together and they form only the anterior sheath. So this is the medial aspect of the anterior abdominal wall. Now, if we look at the lateral aspect, there is skin. Skin, if the skin is denuded, this is number 2. This is the subcutaneous tissue. Then you can see the lateral areas that there is this muscular external oblique, which is coming down from the costal margins and coming here. And as it grows towards the midline, then it becomes more aponeurotic and muscular fibers are comparatively less. And you can see the direction of the muscles. It is coming downwards and inwards and forward. And internal oblique, which is more in a kind of different direction. Then transversus abdominis, this is encompassing, totally embracing the abdomen as such. Then the fascia transversalis, which is below that. And then the 7th layer here is the peritoneum. And if we look at the median aspect, then this is the median aspect, which has been surface marked on the skin here. So first skin, then subcutaneous tissue. And then here we see the anterior wall of the rectus sheath, which is formed by the extension of all the three muscles, external oblique, internal oblique, and transversus abdominis, which form an aponeurotic sheet. And this is over there. And below that is the rectus muscle, which from the costal margin is xiphisternum and comes here to the pubic symphysis. As a matter of fact, it originates from here and its insertion is over there. And if the rectus muscle is now removed, this is the posterior rectus sheath up to this place, which is 1.5 inches below the umbilicus. And below that, there is no rectus sheath here. And then, of course, the peritoneum. And some of the blood vessels are shown here in this. So that is the difference between how the muscles are in the lateral part of the anterior abdominal wall and how they are represented in the medial part. If we look at rectus, the external oblique, it originates from the costal margins, fleshy, from lower 8 ribs and comes down over there, inserted by fleshy fibers as well as aponeurosis. Outer lip of the iliac crest, that is the insertion point or medial point. This is the detail about it. Downwards, forwards, and medially, that is the direction of its fibers. And its nerve supply is from T7 to 11 and T12 subcostal nerve. Looking at oblique, internal oblique, anterior 2/3 of the intermediate line of the iliac crest, that is where it is attached. The lateral 2/3 of the inguinal ligament, and lumbar fascia, and it's inserted into, because it is going from below upwards. You see, this is the direction of the fibers. And so therefore, if we look at external oblique, it is originating from the ribs and coming down to get attached onto the iliac crest. And if we look at the internal oblique, it is originating from here. So in an opposite direction. And then it is inserted into the lower 6 costal margin xiphoid process, and linea alba, which is the middle line where the rectus, there where the aponeurosis they meet. And the direction of its fibers is upwards, forwards, and medially. And nerve supply again, like external oblique, T7 to T12, iliohypogastric and ilioinguinal nerves. These are the nerves that we'll talk about also. Transversus abdominis originates from lower 6 intercostal cartilages, and it runs medially, and it is inserted into lateral 1/3 of the inguinal ligament also here, and also anterior 2/3 of the inner lip of the iliac crest. So this is the insertion, and starting from xiphoid process, linea alba, pubic crest. So this is the origin, and this is the insertion. The direction is horizontal. So here you see that, like if you look at the myometrial musculature is crisscross. It's interlacing. It's crisscross fibers. And why I'm referring to myometrium, it's just a digression. Myometrial fibers, they have this property of interlacing, and which help them to grasp the blood vessels within that. And that's why when it contracts, it constricts the blood vessels going through that, and thereby stops the hemorrhage. That's why why it's important for the myometrial muscles to constrict. Now, in the anterior abdominal wall, it is not just one muscle which is crisscrossing. It is the 3 muscles which provide that protection and action in 3 different directions. We've seen that external oblique runs forwards, downwards, and medially. And external oblique in a different fashion, although medially, but it is running upwards. So it is providing strength in a different fashion. And then the transversus abdominis, which is encompassing the abdomen and holding it all along around that. So again, nerve supply of all these 3 muscles is from segments T7 to T12. And then the rectus abdominis, it originates from the pubic crest here, along with the pyramidalis, which is superficial to that, to rectus. And then it runs upwards, and it's inserted into the 5th, 6th, and 7th costal cartilages and the xiphoid process. So this is where it is inserted. And you see these intermissions in these, which are about 3 to 4. And these are the segments, and where these are tendinous intersections, which indicate that the muscle arises from a number of myotomes fused together. Surgical importance is segmental nerve supply. And if there is hematoma formation, that will be limited to that particular segment. It is localized. And well, we'll talk about paramedian incision. It is displaced laterally. Paramedian incision is given onto one side of the midline. This is the midline incision would be here, where we'd be separating it. A paramedian incision left or right would be to one side of the midline. And in that, what we do is that then after giving that skin incision, then we go for the linea alba, find that, and then retract the muscle onto that one side. So we do not cut, or we do not cut the muscle, or we do not separate its fibers, but we retract it as a whole. Displaces medially, laterally. Nerve supply comes from the blood supply, and nerve supply particularly comes from lateral aspects, although the blood supply is coming from below and from upwards. Now, this is the rectus sheath posteriorly, because you see here, this is the umbilicus, and this is the rectus sheath. In most of our gynecological and obstetric or cesarean section, we do not even mind where, and we do not look for the arcuate line or the lower margin of the rectus sheath, and we are not even aware whether it exists or not. It is only in midline incisions, because that is the other incision which we employ many times for large fibroids or large ovarian cysts, in which we sometimes have to go above the umbilicus as well. And then we know that there is this rectus sheath posteriorly. So this is, and then these are the vessels, blood vessels. Inferior epigastric artery, it runs from, they say it is a branch of external iliac, which goes from here upwards. And then that is the terminal part of the internal thoracic artery, which is the superior epigastric artery. आइए मैडम
सारी नाइट में पढ़ा थी ना
काफी कर ली है
इतनी बड़ी मेहनत में तुम लोग भी किया तुम लोगों को नहीं पता
अच्छा तुम्हें पता
मुझे पता है पता नहीं कितने दिनों से बैठे
so this is the posterior aspect और तुम्हें पता है हमारी पहली डॉक्टर जो है वो when my lecture was already 5 minutes वो पहली डॉक्टर उसको बताई थी तो Acha, here you see the rectus sheath. This is the rectus sheath which is above the umbilicus or above the arcuate line. Here you see that the external oblique runs in front of the rectus muscle. Transversus abdominis would run, or its aponeurosis or its extension to linea alba would run behind rectus muscle. But the aponeurosis of internal oblique, that will split here, and part of that would be in front of rectus and part of that would go to form the posterior rectus sheath over here. This is above the below the we were looking at this is above the arcuate line, and this is falciform ligament which goes on to divide the, actually this goes towards the liver and goes to divide its left and right lobe, falciform ligament, and provides support to the liver also. And this is important. It is important to learn that it would be going a little to the right, and that's why we generally, if we are extending an incision above the umbilicus, we extend usually on the left side, and we need to take care at that time that we do not unnecessarily cut the falciform ligament. So this is the posterior layer of the rectus sheath, and this. Now here below the arcuate line, then all three components of aponeurotic components of these three muscles, they run in front of the rectus muscle. And then there is medial umbilical ligament and median umbilical fold. These are the remnants of uricus and also of the umbilical vessels. So this transversal fascia is there, and this is all median umbilical fold. These are the remnants, and you would see while incising the peritoneum that there is that white thick, not very thick, but reasonably quite prominent small band running upwards. That's from the top of the bladder running up to the umbilicus. That is the remnant of uricus. This is blood supply of anterior abdominal wall in inferior epigastric artery, a branch of external iliac and deep circumflex, and superior epigastric artery is the terminal part of the internal mammary or internal thoracic artery.
छोटी सी बात ये कह दूं if you don't mind. इसमें बड़ी important चीज है, आप लोग जब abdomen खोलते हो तो कई दफा even if you haven't opened the whole abdomen और आप muscle के ऊपर होते हैं तो there's quite a bit of bleeding. So the important point to remember is कि inferior epigastric artery तो काफी बड़ी artery होती है जो कि वहाँ run कर रही होती है, and sometimes its tributaries are also reasonably healthy. So you have to be careful about this artery. Okay, there can be a lot of bleeding, and women who develop abdominal wall hematoma later on are the ones जिनमें हमने इसको properly diagnosed किया. So I think knowing the anatomy is very important in that perspective as well. That you know that there is this inferior epigastric artery, you know that you have to be careful about it, and you know that you have to ligate it appropriately so that वो जो होता है ना press कर दिया bleeding खत्म हो गई, वो bleeding बाद में आनी है. अगर आप उसको प्रॉपर्ली लाइक सो यू हैव टू बी केयरफुल अबाउट दिस। एक्सटर्नल आर्टरी काटती है तो खासी बड़ी आर्टरी होती है जहाँ से काफी आ रही है। So that is the concept that you need
ये
to have
इधर
in
से
your
आगे अगर आप देख लो कि ये यहाँ पे जो ग्रीन है, ये इस पे एम्फेसिस करने की बात है। inferior epigastric artery rises from external iliac and is an important artery supplying the anterior abdominal wall. One should take care not in actually to ligate. What we do
No,
ligate
if it is bleeding,
what we are ligating are actually the branches of those arteries,
absolutely,
because this is lying just above the peritoneum and over that. So superficial, and then sometimes there is a different branch. We need not go into that. Just remember that there is inferior epigastric artery, which is a branch of external iliac, which supplies this area, and superior epigastric, internal thoracic or internal membrane.
सुपीरियर एपिगैस्ट्रिक है उससे हमारा वास्ता नहीं पड़ता।
हाँ,
वो बहुत ऊपर होती है। वो अगर आपने हम लाइटर से ऊपर आप जा रहे हैं, then you might get into that, but otherwise जो हमारी रूटीन है हमें inferior epigastric artery की tributaries को देखना।
ये इसमें भी थोड़ा सा एसेंशियली जो है वो कर दिया वो। अब थोड़ा सा नर्व्स के बारे में भी वो कर लिया जाए। ये क्या आ रहा है कैंसर करने का, कंफर्म योर
सेव कर लें।
नहीं, मैं ये मेरे पास नहीं आ रहा। ये जरा देखें आपके पास आ रहा है कोई? मेरी तस्वीर में नहीं आ रहा, उधर आ रहा है ये इसको। Alright, some of these nerves, not all, some of these nerves, ये iliohypogastric और ilioinguinal nerves हैं। ये यहाँ पे इस तरह से आ रही हैं और ये इधर ये है, these are the important iliohypogastric, L1 वगैरह से निकलती हैं ये वो, and these come here and they supply the lower abdominal wall, as well as then they go out through the internal inguinal ring and they supply the anterior part of the vulva here. Here, this green line is the, or darker line is the ilioinguinal nerve, which is going over here. And then I have
So basically, it's going over the iliac crest.
I have given here
Famous of the pubic abscess.
no, sorry. ये क्या हो गया?
सर जब तक क्वेश्चन कर लो।
हाँ जी कर लें।
सर सिजेरियन सेक्शन में ये इलियो इंग्वाइनल और इलियो हाइपोगेस्ट्रिक नर्व ही डैमेज होते हैं ना, कट के पेशेंट बाद में कंप्लेन करते कि मुझे।
हम आएंगे उसकी तरफ। अभी मैं आपको एक वीडियो भी दिखाने लगा हूँ। ये अगर सॉरी ये इस पे
शेयर कर
शेयर
स्टॉप शेयर
stop share. Now here I have given YouTube link, वो क्या होता है, लिंक होता है। उसके लिए आपको ये मैं I would this is only 3.5 minutes video. इसका साउंड एक मिनट है। हाँ ये से निकल गया, क्या हुआ?
नहीं, मेरे मुताबिक आपको इसको स्टॉप शेयर करना पड़ेगा।
मैं ज़ूम में हूँ कहाँ पे? मेरा ख्याल है मेरा ज़ूम बंद हो गया।
नहीं, अभी आप क्या वो लीव मीटिंग आपको कह रहा है, ये कह रहा है लीव मीटिंग, इसका मतलब है
यू आर शेयरिंग कहाँ पे हूँ? न्यू शेयर
असल में जब ये abdominal wall में हम करते हैं ना, तो many people think कि ये क्यों कर रहे हैं।
हाँ आ गया इधर, अब आ गया इसको।
So it seems rather superfluous, इतनी डिटेल में जा रहे हैं, but actually when you
ये है, ये आपके इस सवालों का काफी जवाब देगा यहाँ पे। ये जरा इसको आप इसकी आवाज नहीं आएगी, इसको जरा देख लें। इन इलियो इन्ग्वाइनल नर्व आ रही है, इस नीचे कमेंट्स लिखे हुए हैं, वो पढ़ते जाएं। And then you can access that, you go onto this, and ये देखो ventral ramus of L1 से arises with iliohypogastric or ilioinguinal, दोनों इकट्ठी निकल रही हैं. And if you look at the captions below, which is white and black, that is the text of what is being spoken at that time. But you can have this link, and then you can observe, listen to it and watch it. But this is important. As you said, that these nerves can be damaged if one is very careless. That's number one. Or if the incision is extended too laterally, then these two nerves can be damaged, or if we cut it too much. Generally, when we are in Fenner steel incision, we are cutting the epineurosis or the anterior or rectus sheath. I shouldn't be calling it anterior because there is only one rectus sheath at that place. When we are cutting the rectus sheath, we cut it to some extent, but both these nerves generally are further lateral away, and therefore there is less damage for that. But that's something to be said about not cutting throughout and stretching it, and retracting the muscles laterally, even these muscles, so that you do not cut major or larger blood vessels, and you also do not cut the nerves, because they have motor innervation, transverse abdominis muscle, and internal oblique muscles. Otherwise, they'll if that is damaged, then they'll become weak. And there are also sensory nerves for the skin of superior medial thigh and groin, and in males, the anterior 1/3 of scrotum. In females, the anterior 1/3 of the labia majora and clitoris. So their sensory and motor functions are important. The clinical significance of these nerves is that if they get damaged, then during surgery, that can result in weakening of the transversus abdominis muscle and internal oblique muscle, and result in inguinal hernia, and obviously of weakness of the anterior abdominal wall. So this is 3.5 minutes video, which is important, and which is which explains the whole thing quite nicely.
सर
जी,
सर क्या हम कह सकते हैं कि यही रीजन है एब्डोमिनल वॉल वीक, मोटर जो सप्लाई है उनकी वीक होने की वजह से सिजेरियन सेक्शन वाली जो पेशेंट्स हैं उनको अक्सर लोअर टमी जो है वो निकल आती है, या वहां पे फैट की वजह
नहीं, वो नहीं है, not necessarily. You would see that protuberance of lower abdominal wall even otherwise, because if you look at this diagram on the right side, where this darker nerve is given, it is we have to be very careless, we have to be ruthless to damage this nerve. Actually, if you look at here, it is going along the internal iliac crest, and here comes almost to the pubic symphysis, just short of that.
In a normal situation, यहाँ तो incision होता ही नहीं है.
हमारा incision जो होता है वो थोड़ा सा ऊपर होता है इसके, लेकिन वो इसकी वजह से नहीं होता. वो हमारा incision यहाँ इस जगह के ऊपर होता है, इस जगह पे. अब हम आ रहे हैं उस तरफ. लो जी, अगर सर्जिकल इंसिजन्स की बात करनी है तो वो when we approach and we want to get access to some tissues which are below that area of the skin, then we make an incision to get access to that particular tissue for whatever reason that we need to do that. And this is generally an advice that that incision should be chosen, which is considered to be the most suitable for that operation to be performed. For example, let's say a cesarean section. What kind of incision would there be? So there can be two kinds of incision: a vertical incision and a transverse incision as well. When I was training at that time in late 70s, we used to make a midline incision in our department, and we would really scoff at people making transverse incisions. And the surgical colleagues, they would, whenever we called them for some assistance, they would come and they would tell us that now you make these incision, and later on these women come to us for incisional hernias. So and then there of course then we changed over to transverse incisions, and the objectives of giving an incision is to get access, and also we sometimes need to extend that. So that also is important, and then also that it should end up in proper closure. These are the principles. Incision should be long enough for good exposure. It should not be so that you do not struggle in a comparatively short, but at the same time, it should not be unnecessarily long. It is better to split the muscles than to cut the muscles. And so far as required, one should avoid cutting nerves and vessels, and that can be done by, or that can be avoided by stretching. Retract muscle and abdominal organs towards neurovascular bundle from where they are coming. For example, the nerves are coming from laterally, so we can retract the muscles and the organs laterally, where so that the neurovascular bundle does not get unnecessarily stretched. And transverse incisions are better than vertical, close the wound layer by layer. And if a drain has to be passed in, it should be passed in through a separate incisions. An ideal incision would allow ease of access to the desired structure, and that would be able to be extended if there is need for that. And again, it is repeated that muscle should be split rather than cut. And then that incision should also have the capacity to heal with minimum scarring. Langer's line, we generally are told about giving an incision in line with the Langer's lines, because incisions made parallel to Langer's line may heal better, or would heal better and produce less scarring than those that cut across, because the collagen fibers below the skin, they'll otherwise be cut. These lines are parallel to, or they show the direction of the collagen fibers. The various abdominal incisions that we use, not many of these are in the upper abdomen. These are the lower abdominal incisions. Actually, number 6 or number 7 that we use. Number 7 is the midline incision, and number 6 is paramedian. And here, lower abdominal transverse incision or transverse incisions are also shown. We are not, we don't give McBurney's incision or this Land's incision, but we mostly give this Fenton steel incision. And we also do not give, usually do not deal with inguinal hernia. So this is the incision that we most commonly give. Or there is a transverse incision, which is called Joel Cohen's incision, which is a little above this, about 3 centimeters above the area where we give the Fenton steel incision. So I'll generally concentrate on midline, paramedian, and the lower transverse incision. These are various varieties. We are not concerned with this one, but what we are concerned with is this, or sometimes Joel Cohen's, but that is not practiced here. This one is the incision which we would give mostly.
Or you did Chinese again?
Yeah, this is too low.
This is too low, and this comes almost over the pubic symphysis, which can result in a lot of pain for the patient. So when you are giving an incision, make sure that you do not give the incision on the pubic symphysis. ये बहुत painful होता है, और इसीलिए जो retracted RPM बहुत ज़्यादा खींच रहे होते हैं for a routine cesarean या routine abdominal procedure, वो नहीं बहुत ज़्यादा खींचना चाहिए, because if you are pulling against the pubic symphysis, the patient will in the post-operative period be extremely uncomfortable. और during surgery आप bladder को unnecessary pull कर रहे हैं, जिससे bladder की bleeding और sometimes वो जो blood stain urine आता है उसकी वजह से. So be careful with that.
ये जोल कोहेन, इसके बारे में बाद में बात कर लेंगे. वर्टिकल इncision, ये नीचे भी है, ऊपर भी है. Upper midline incision, lower midline, a single. It's favored in diagnostic laparotomy as it allows wide access to abdominal cavity. वो आप लोगों ने देखा हुआ, कभी कभार हम करते हैं, जैसे ओवेरियन ट्यूमर है, लार्ज फाइब्रॉइड है, उसके लिए उस तरह से करना हो. मीडियन इncision maybe upper midline, lower midline, single incision, or वो है. Lower midline incision from the umbilicus superiorly to the pubic symphysis inferiorly allows access to pelvic organs. Peritoneum should be opened in the upper part as far as possible to avoid injury to the bladder. This is paramedian incision placed 2 to 5 centimeters lateral to midline over median aspect of bulging transverse convexity of rectus, provides access to lateral structures, avoids injuries to nerves, limits trauma to rectus muscle, permits good restoration of abdominal wall, can be extended by slanting the upper end of incision. It is time consuming, disadvantages, needs to be closed in layers, difficult extension superiorly as limited by the costal margin, tends to strip the muscles of their lateral blood and nerve supply, resulting, if one is not careful and one is not accessing the abdomen through the linea alba part. Vertical, these are the amount of bleeding is less, no muscle fibers are divided, no nerves are injured, good access to upper abdomen, very quick to make as well as to close, can be extended full length of abdomen, curving around umbilicus. Care needs to be taken just above the umbilicus where the falciform ligament is, midline scar, which obviously is ugly looking and which is quite apparent. And bladder injury, well, that can happen with any incision. Transverse incision advantages are better cosmetically, stronger than vertical, less painful. Disadvantages, limited exposure of the organs. Now, this is the clinical importance of anatomical structure. Superior, inferior, superficial inferior epigastric vessels. Isolate, ligate on line from femoral vessels to umbilicus. Here, insertion of pyramidalis identifies midline. Anyway, these are various points. Complications of abdominal incisions, hematoma, stitch abscess, wound infection, wound dehiscence, burst abdomen, fistula formation, wound pain, incisional hernia, later adherence and its complications, and unsightly scar. The factors, these are not all, but some of them are that what type of surgery are you doing for, this is something which involves general surgery as well. And the type of incision, the patient's physique, if she is obese, then of course there is likely to be more complications. Cough, ascites, nutrition, diabetes, immunosuppression, these are the factors which contribute towards the healing of the wound.
Very good.
Presentation.
आप जानते हैं जो बता दूं
हमारे पास 15 मिनट है, अगर आप करना चाहो
आपके पास वो है लगा दो।
1 मिनट में देखता हूँ वो मैं ये जो हाँ लड़कियों के सवाल हैं जरा देख लो अगर उनके हैं।
We are ready for questions. वालेकुम सलाम. That is the only question.
एक मिनट.
So if you have any questions, we'll be happy to answer. Otherwise, we will start the second presentation.
ये तो बढ़िया था स्लाइड से इसकी.
2 घंटे बोल सकते हैं.
नहीं 2 घंटे नहीं.
I try to be. बस काफी बातें आपने कर दी हैं actually.
यहाँ पे आप.
So I'm just going to talk to you a little bit about how to avoid and manage injury to the pelvic organs during tubal ligation. And once I go through the presentation, you will realize that this is actually related to what Professor Farrukh Zaman was talking about and a lot of anatomy that he has highlighted regarding the anterior abdominal wall that needs to be understood when we are talking about injury during the pelvic organ ligation. So I'm going to talk a little bit and I will omit the anatomy of the pelvis, but we'll just touch it from there, ruling out the contraindications of the procedure, counseling, good analgesia, technique of the procedure, and identification of complications and what to do if you've got a problem. So basically, this is just to highlight the, do we have a pointer?
ये इसके साथ था. Excuse me.
So just want to highlight to you the anatomy of the reproductive tract. And if you, I'm sure all of you know this, that you look at the uterus, you look at how is the bladder placed onto the interior surface of the uterus. So if you're going to do a procedure with a full bladder, the chances of injury to the bladder are going to increase. And then you need to look at the reflection of the peritoneum, how it dips into form the pouch of Douglas on the posterior surface of the uterus. And if there is, and just trying to relate the anatomy, that if there is some collection in the peritoneal cavity, then it would on pelvic examination be expressed as a bulge in the posterior pouch of the peritoneum. So I think this is important to understand. This is basically to talk about the site of the tubal ligation, and most of the time when we are doing tubal ligation, we are doing it at the first third of the fallopian tube. If you go too much near the ampulla, then there is a possibility that there is greater probability of recanalization of the fallopian tubes and also failure of the process. So there are various ways of doing the fallopian tube. You can put a band, you can clip, and you can tie and cut. So most of the times during open surgery, what we are doing is tying and cutting of the fallopian tube. Now, if you're looking at the injuries of the pelvis and how can they happen, so the various kind of injuries that can happen can be resulting in bleeding, hematoma formation, introduction of infection, and complication related to drugs if journal or anesthesia is given or IV analgesia is used. And what are the types of injuries that can be produced? There are injuries to the bladder, fallopian tube, round ligament, ovaries, intestines, and the ureter. And I think that the most important thing that you need to remember when you are doing ligation of the fallopian tube is, especially if you have not identified the fallopian tube appropriately and you are pulling on the round ligament, that the probability of injury to the round ligament increases, and that results in a lot of bleeding. One of the points that you need to remember over here is that this is a lecture which I have prepared for girls who are doing family planning services and they are doing only tubal ligation through a mini lab. So keep that perspective in mind. And when I say poor identification, that is important because in mini lab, it is very important to differentiate between the fallopian tube and round ligament. And it is said that you must look at the.
There was a time at when it was recommended that when you ligate the tube and you cut that particular section, you send it for histopathology to make sure that there is evidence that you ligated the fallopian tubes and not the round ligament.
Yes, and I think it is also important to remember that when you are ligating the fallopian tube, you must identify the ampullary end of the fallopian tube and you must look at that and then confirm that it is the fallopian tube. And also it is important, I don't know whether you'll be able to look at it or not. In one of the slides, it's going to come that you have to know the anatomy of the fallopian tube and the round ligament. And if I can ask the people sitting over here, where is the fallopian tube situated? Can anybody tell me? vis-a-vis the uterus fallopian tube कहाँ होती है?
On the upper lateral aspect of the uterus.
Upper lateral aspect of the uterus. Anybody else? Okay, so नहीं पता. मैं इसका जवाब ऐसे लेती हूँ कि नहीं पता हमें. So हमें understand करने की जरूरत है. Where is the fallopian tube? The fallopian tube is the highest most tube on the fundus of the uterus. तो जो fundus के साथ सबसे बड़ी चीज आएगी, that is the fallopian tube. और round ligament जो होती है, that is almost in the middle. और वो जो होती है वो anterior surface of the uterus पे होती है. अभी हम इसको दोबारा भी देखेंगे. So now if you look at it, that is why it is important when we say that you need to know your anatomy. जैसे सर पढ़ा रहे थे, तो मैं सोच रही थी कि सर इतनी ज्यादा चीजें पढ़ा रहे हैं, तो हमें ये चीजें इनकी significance भी पता होनी चाहिए. Only then we are going to try to learn them. So let's start with the bladder. Bladder empty होना जरूरी है. Bladder की anatomy जैसे कि मैंने शुरू में आपको bladder की reflection दिखाई थी, वो पता होना जरूरी है. And you should be able to differentiate between the visceral peritoneum of the bladder कि वो कहाँ से आता है, low uterine segment कहाँ तक होती है, वगैरह वगैरह. For ureter, you need to remember that the ureter is in the posterior leaf of the broad ligament. So काफी gynecologists जो हैं वो ureter से word करते हैं. So anterior leaf of broad ligament में ureter है ही नहीं, so you cannot injure. It is in the posterior leaf, and that is why the anatomy of the ureter is important to know. Regarding the round ligament, as I said, that it is on the anterior surface of the lower side of the uterus, and I'm going to show you a diagram in which it can be elucidated. And how do you differentiate it from the fallopian tube? Fallopian tube is the highest point on the fundus. So there is no way that you will find the fallopian tube in the middle of the uterine body. ऐसा नहीं होगा. और ओवरीज के लिए जो टिप है वो ये है कि ओवरीज के आइडेंटिफिकेशन तो आपके लिए इशू नहीं है, लेकिन ओवरीज को पकड़ के ट्यूब पर ढूंढने की कोशिश ना करें. So if you're pulling at the ovaries and you're giving traction to the ovaries, there is a probability that the ovarian vessels will start bleeding and they're difficult to control, especially if you're doing a tubal ligation in local analgesia. और intestines जो है वो रास्ते में नहीं आनी चाहिए. So when you're doing a ligation, you must remember that if the patient is in pain, she's going to push. All of these two parameters, pain of the patient and the pushing of the patient, will increase your probability of injury to the intestines. अब अगर आप इसको देखें तो this is actually showing you the posterior aspect of the broad ligament. And if you look at it, तो जो मैं बात कह रही थी कि फंडस पे सबसे ऊपर जो चीज है, that is the fallopian tube. ये fallopian tube जा रही है, ठीक है? And if you look at it, the second thing which is closest to this is the ligament of the ovary, जिसको infundibulopelvic fold भी कहते हैं. तो ligament of the ovary जो है वो important है, that is close a round ligament. इसमें नहीं नजर आएगी because this is the posterior aspect, लेकिन वो तकरीबन इस जगह पे होती है. इतना फर्क है round ligament का और उसका. And if you look again over here, again it is showing you the same thing. The highest point of the uterus is the fallopian tube, then the infundibulopelvic fold और ovarian ligament, sorry, the ovarian ligament, और सबसे आखिर में अगर आप यहाँ देखें तो तकरीबन इस जगह पे ovarian ligament होती है, ठीक है? Again showing you the same thing from a different angle, just to re-emphasize the point कि क्या हो रहा है, ठीक है? Now let's look at the anterior abdominal wall, and I'm not going to repeat this because all of you have heard a lot about it since this morning. So वही inferior epigastric artery वाली जो बात हमने की थी कि this is important identification and knowing the anatomy of the inferior epigastric artery, knowing कि उसकी fine vessels होती हैं जिनको आपने cauterize करना होता है before you move on. Again, I'm not going to go into this, but these are actually, this is actually showing you the place जहाँ सबसे ज़्यादा bleeding की probability है, तकरीबन इस जगह पे. ये मेरा काबू में नहीं है ज़्यादा, तो मैं इसलिए इसका कुछ नहीं कर सकती. So when you're planning to do a tubal ligation in these in women, you have to make sure that there are certain things that you. So again, as I said, that this presentation was made for people who are doing it in the family planning center. और जो कि पार्ट 2 की एवएफसी केस नहीं है, तो उनके लिए जो इम्पोर्टेंट चीज है और बाकियों के लिए भी वो ये है कि इफ यू आर प्लानिंग ऑन डूइंग अ मिनी लेप्रोटमी फॉर ट्यूबल लाइगेशन, यू हैव टू मेक श्योर दैट देयर आर नो adhesions. You want to know that the uterus is not enlarged because of adenomyosis or fibroids. Adequate analgesia has been given and the patient should not be morbidly obese. अगर इन चार चीजों में से कोई चीज है, then this is not a patient for you to do. If you want to avoid complications during a procedure, the most important thing is to rule out contraindications. And for ruling out contraindications, the most important thing is evaluation of the patient. So a good history and an appropriate examination will make sure कि इस किस्म की complications वाली patients को आप choose ना करें. So if there is a morbidly obese patient, she can be referred to a better facility where general anesthesia may be available or a laparoscopic ligation could be done for her. So when you are trying to evaluate these patients, her LMP is important because you don't want to do ligation on a pregnant woman. The uterine size, the version of the uterus, mobility of the uterus, and whether there is any tenderness or not. And if the mobility is restricted, it means that there are adhesions. So everything that you are doing has an implication from the perspective of the patient. Counseling of the patient is important because not only are you trying to give information to the patient regarding a problem, but you're also trying to prepare the patient for the procedure and also telling her of the pros and cons of the procedure. So for example, अगर आप family plan बहुत तेज जा रही हूँ, मैं तेज इसलिए जा रही हूँ, slides काफी है. So for example, if you're trying to prepare your patient, you have to tell her of the small probability that things might not go right. And that is a difficult thing to counsel a patient because वो भाग भी सकती है आपसे, ligation नहीं कराएगी, तो you have to know how to do it. Anesthesia choices काफी सारी होती हैं, लेकिन family planning centers में ज्यादातर local anesthesia दिया जाता है. So technique की बहुत ज्यादा डिटेल में हम नहीं जाएंगे, लेकिन simple बात, as I said, that we need to evaluate, we need to know the LMP, we need to know the size and the direction of the uterus, we have to make sure that the uterus is mobile, the patient is pain-free. Once you are opening the abdomen, then the important thing when opening the abdomen is that you have to ensure that the bladder should be empty. Because आपने इसका incision देना है, there is a question.
PTL effective and well laparoscopically effective. When after how many times?
मैं question नहीं समझी आपका. After how many times का क्या मतलब है?
मैम कितने टाइम के बाद जो है हम उनको ये अलो कर सकते हैं कि अब ये जो है वो BTL इफेक्टिव हो गई है या हील हो गई है, देन शी कैन एंड
वो तो उसी वक्त से
वैसे
इमीडिएटली।
तो उसका इफेक्ट इमीडिएट होता है as
जी
soon
मैडम।
as you tie the tube,
हाँ तो वो
as soon as you tie the tube,
ओके
खास
मैडम।
तौर पे अगर आपने पोस्ट मेंस्ट्रुअल पीरियड में किया है, इफ यू आर डूइंग इट इन द मिडल ऑफ द साइकिल पोस्ट ओवुलेशन, तो फिर तो प्रेगनेंसी हो सकता है, हो भी जाए. So you have to make sure that you're doing it at the right time during the menstrual cycle.
उसके बाद कॉन्ट्रासेप्शन की जरूरत नहीं होनी चाहिए अगर प्रॉपरली लाइगेट कर दी।
ठीक है, so for before,
नहीं हिस्टेरोसल्पिंगोग्राफी नहीं करते उसको
नहीं, you don't need to. You don't need to do a hysterosalpingography to confirm.
प्लीज डोंट डू दैट।
ये ना कहीं मशवरा दे
ओके
देना.
मैडम।
Okay, so once you have opened the abdomen, you make sure first that the bladder is empty. You have opened the abdomen. Again, उसके लिए जो मैं बात कहूंगी वो ये है कि patient को पेट फ्री होना चाहिए. Then you have put in a sound in the uterine cavity. तो sound के जरिए आप uterus को elevate करके you identify the fallopian tube. और इसके अंदर जो सबसे important बात है to reduce the chances of complications, that is accurate handling and gentle handling. You cannot be rough when you are opening the abdominal cavity and when you are trying to identify the tube, and you have to ensure hemostasis. अगर आपको अपनी limitation पता है कि you are not well versed with the procedure, then you must have somebody supervise what you are doing, and there should be a facility to call for help. So what can be the immediate complications? Incorrect anatomical site of sterilization, bowel, bladder and blood vessel injury, conversion to laparotomy, transection of the fallopian tube, uterine perforation or cervical laceration. इसमें सबसे कॉमन जो कॉम्प्लिकेशन है दैट इज द यूट्राइन परफोरेशन. और यूट्राइन परफोरेशन की सबसे कॉमन रीजन ये है कि हम उसको बहुत ज्यादा पुश कर रहे होते हैं कि एक दफा पोस्टमार्टम पेशेंट्स भी होते हैं एंड इट रिजल्ट्स इन परफोरेशन. सो अगर परफोरेशन हो जाए तो इट डज नॉट नीड टू बी कन्वर्टेड इनटू अ लेप्रोटमी. आपने देखना है जिस पॉइंट पे परफोरेशन हुई है वो ब्लीड कर रही है कि नहीं कर रही. अगर कर रही है तो उस पे स्टिच लगाते. दैट इज ऑल दैट यू नीड टू डू. काफी लोग इसको लेप्रोटमी में कन्वर्ट करने के बारे में सोचते हैं जिसकी जरूरत नहीं है. Post-operatively, there can be bleeding from the skin incision or inside the abdomen, pain after the procedure, infection, damage to the organs, and incomplete ligation. So I think this is again dependent on the skill of the person who's doing it. But a very important thing to remember is that you must give pain relief to the patient after the procedure, and you must tell her about the possibilities of complication and what are the signs by which the patient should come back. So if the patient has got persistent nausea and vomiting which lasts more than 24 hours, if she has high-grade fever which lasts more than 24 hours, if there is a problem with the incision in terms of bleeding or swelling or redness, or if she has heavy bleeding with clots, then she needs to come back. So what are the solutions to your problems? The solutions are, सबसे बड़ी बात यह है कि pre-operatively appropriate assessment of the patient, knowing our limitations, having a liaison with the surgical and gynecological team, ताकि अगर हमें जरूरत हो तो they are available. We have to make sure that if we think that something has gone wrong, please do not close the abdomen. If you are suspecting an injury to the bladder or something which is not appropriate, you must raise alarm, you must stop the procedure, and you must seek for help immediately. And we have to follow up the patient till she goes home and not leave her alone if we transfer her to some second order facility.
वेरी गुड।
Yeah.
टाइम पे कर दिया।
Thanks, sometimes इसलिए मैं थोड़ा कही हूँ questions.
प्लीज आस्क क्वेश्चंस, यहाँ पे झिझकना नहीं है, जैसे भी है आप इसके लिए।
अगर आपने वो हिस्टो वाला क्वेश्चन भी पूछा ना, आई एम हैप्पी यू आस्क्ड.
हाँ
because you asked and now you know कि हमें हिस्टो की जरूरत है.
इसी तरह से ये जो कॉन्ट्रासेप्शन वाली बात है, ये it may appear to be insignificant, but you must clarify your concepts about this in this forum because it is important.
I think
You see, if we go into the different types of again how we ligate the tubes, there are different methods. You make a loop of that, you cut a segment of that, and you separate the both ends. You portrays the both ends, or you apply a clip through laparoscope, or you apply a fallopian ring, which used to be there, in which the tube used to be pulled up, made a loop of that, and then ring would be slipped onto that. So there are various methodologies of that, laparoscopically or through mini laparoscopy. But the objective is to generally occlude the lumen of the tube. And once it is done, because these are reliable methods. Once it's done, then you need not go for any tubal patency test. The reference that I made about the histopathology, sending it for histopathology, that was earlier. That was 40, 50 years ago.
मैंने सिर्फ एक बात यहाँ कहनी है. Dr. Yasmin has asked a question about mini lab, laparoscopic clip, and hysteroscopic method. All three are effective actually. The thing is that what facility do you have and what are you comfortable doing? So whatever you might do, they are all equally effective. So इससे कोई फर्क नहीं पड़ता. Lowest failure rate of tubal ligation, I think वो Parkland method होता था, जिसको वो कहते थे.
Method में नहीं, वो ये है कि any method in which either when you are doing it mini laparotomy, for example, then you cut in both the ends are separate. वो कौन सा
Parkland ही था.
मैं ट्रॉय या कौन सा
उसमें वो करते थे कि उसको कट करके उनको दोनों एंड्स को बरी करते थे. आजकल वो
नहीं वो करने की जरूरत नहीं है.
आजकल पोमेरॉय करते हैं.
पोमेरॉय जो है ना, पोमेरॉय हैज द मोस्ट फेलियर रेट एक्चुअली. पोमेरॉय का फेलियर रेट है जिसमें लूप बना के आप टाई करके छोड़ देते हो. आप वो उसका सेगमेंट भी नहीं करते और सेपरेट भी नहीं करते. उसका फेलियर रेट ज्यादा है. डॉक्टर साहब भी आ गए. अस्सलाम वालेकुम जी.
सर एक क्वेश्चन है. वालेकुम सर.
वालेकुम अस्सलाम जी.
अच्छा क्वेश्चन है कि देयर वाज अ क्वेश्चन इन लास्ट अटेम्प्ट मैंने दो डिस्कस किया था, तो वो बता रहे थे कि सिनेरियो कुछ टाइप का था कि पैरा 3 केम फॉर लेप्रोस्कोपिक BTL और she was told that during the procedure her IUCD was removed and after 1.5 months she came with UPT positive. तो उसको सर कैसे हमने यानी कि हमने इंश्योर करना था कि ये लेप्रोस्कोपिक BTL उसकी सक्सेसफुल होनी चाहिए थी.
लेप्रोस्कोपिक लाइगेशन के लिए पेशेंट आई थी और लेप्रोस्कोपिक लाइगेशन हो गई थी.
हाँ, during the procedure she was using IUCD. IUCD was removed during the procedure also. And the next 1.5 months.
मतलब ये है कि वो जो प्रोसीजर था वो इफेक्टिवली प्रॉपर तरीके से नहीं किया गया था. Had that procedure been done, because laparoscopically, as I said, either you apply a clip or you apply a ring, or the tube segment is cauterized and then divided. If you just cauterize it, and that may be insufficient, and if you don't divide the tube, then there is potentially chance of failure. But if you have cauterized and divided the tube, then that shouldn't result in pregnancy.
मैंने एक बात कही है.
एग्जामिनेशन में वो हम सब आजकल कर रहे होते हैं ना, मॉडिफाइड फॉर्मराइज प्रोसीजर है आजकल. हम काय करते हैं उसको कट कर देते हैं.
अगर एग्जामिनेशन में आपको इस तरह का क्वेश्चन आए तो आप सोचें कि व्हाट आर द पॉसिबिलिटीज दैट कुड हैव हैपेंड व्हिच रिजल्टेड हर इन गेटिंग प्रेग्नेंट. सो द पॉसिबिलिटीज आर कि रीकैनलाइजेशन ऑफ ट्यूब्स हो गई,
जो इतनी जल्दी नहीं होती,
जो कि नॉर्मली इतनी जल्दी नहीं होती. Number 2, incorrect method. Number 3, the fallopian tubes were not ligated probably and something else was ligated. जो मैं अभी आपको बात कह रही थी कि round ligament और fallopian tube को differentiate करना चाहिए. So the basic that the person that who is asking the question wants you to objectively look, critically evaluate the situation, what could have possibly gone wrong. तो वो आपने देख के बताना है जो इसमें ये बनता है.
मैडम, इज देयर एनी पॉसिबिलिटी कि वो IUCD जो उसने दूसरे ही दिन निकलवा दी थी, वो भी एक रीजन उसको काउंसलिंग नहीं की गई थी कि जो लेप्रोस्कोपिक मेथड है वो थोड़ा टाइम लेगा इफेक्टिव होने में. तो हो सकता है वो ओव्यूलेशन डेज में रही हो, ओव्यूलेशन डेज में रही हो.
एक मिनट, let me clarify one thing. When the tubes are ligated, then and if it's obviously it is properly ligated, then there is no way that the egg can reach the uterus or sperms can reach the egg. If the egg has already passed the fallopian tube and is in the process of getting implanted in the uterus, that is the only possibility. You don't have to wait for 2 months or 6 months or 2 weeks or 10 days for the ligation to become effective. Ligation is effective right from the time that it is carried out. Now, if there is a failure of ligation, like in Pomeroy's method, there is recanalization, then it will take a little while before canalization takes place. The pregnancy will not show in a short period of time.
Farrukh, मैं थोड़ा कह दूं.
हाँ जी.
ये रुबीना ने बिल्कुल सही कहा था। रजिस्टर नहीं किया हमारे स्टूडेंट्स ने कि आप ट्यूबल लाइगेशन या तो इंश्योर करो कि आप पहले फेज में कर रहे हो, लेकिन अक्सर वो हमारे मुल्क में मेंसेस की डेट याद नहीं रखती पेशेंट्स, तो आपको ये कहना चाहिए कि ट्यूबल लाइगेशन के बाद अगले मेंसेस के बाद ये इफेक्टिव हो।
हाँ, वो इस तरह से कहा जा सकता।
ये कहा जाए सबके लिए कि जिस दिन ट्यूबल लाइगेशन हुई है उस दिन से वो इफेक्टिव नहीं है। अगले माहवारी चाहे वो हफ्ते बाद आए चाहे 2 हफ्ते बाद आए, जब भी आएगी उसके बाद ये इफेक्टिव होगी।
That's right.
For a week or 10 days patient has to use other method of contraception, लेकिन ये मेथड जो है it is 100% और but it is becomes operative after next menses। वैसे आप सबके लिए मैं दास्तान को तो हूँ, एक कहानी सुना देता हूँ। हम सब की टीचर थी डॉक्टर बल्कीस फातिमा। उन्होंने मुझे खुद ये केस सुनाया। कहने लगी एक औरत आई और ये मैं ट्यूबा बांध देती, और उन्होंने मैंने पूछा हूँ इस बात कोई और तरीका तो नहीं है कि मैं क्या 100%। वो औरत आगे 2-3 महीने बाद कि मेरी तो माहवारी नहीं आई, देखा तो प्रेग्नेंट थी। बड़ी मुश्किल से उसको काउंसल किया गया कि मे बी प्रेगनेंसी वाज देयर बिफोर ट्यूबल लाइगेशन वगैरह। चलो अब इसको चलाओ। वो चलाई, उसके बाद मैं गई तो देखा ट्यूबा बिल्कुल ठीक बनी हुई है। मैंने दोबारा बांध दी, जो रेमिनेंट्स थे उनको ही बांध दिया। उन्होंने कहा बिल्कुल नहीं। उसके बाद फिर वो 3-4 महीने बाद प्रेग्नेंट। क्या बड़ी शर्मिंदगी। और वो बड़ी गुस्से में खैर उसको कहा अच्छा ये बच्चा पैदा करो। बिलीव इट कहने कि अगली डिलीवरी हुई तो मैंने उसको सिजेरियन हिस्टेरेक्टमी कर दी कि ये ट्यूब बांधने से काम नहीं बनता, यूट्रस को निकालो। निकल गई। उन्होंने क्या मैं सब कुछ करता है। उन्होंने कहती बिलीव इट शी केम बैक विद एक्टोपिक प्रेगनेंसी। और दूसरी कहानी भी मैं सुना दूं। मैं इंग्लैंड में था तो मुझे पहला जो इंडिपेंडेंट ऑपरेशन दिया गया वो बायलैटरल ट्यूबल लाइगेशन थी, और उस जमाने में लैप्रोस्कोप तो होती नहीं थी, मिनी लैप्रोटमी करके हम करते थे। मैंने ना टू शो ऑफ टू माय हाउस सर्जन्स के मैं बड़ा सर्जन बन गया हूँ, लैप्रोटमी की ट्यूब निकाली बांध दी, फिर दूसरी तरफ से ट्यूब निकाली बांध दी। ऐसे ही ख्याल आया कि मैं जरा रिकन्फर्म कर लूं। देखा जो पहली ट्यूब बांधी थी वो राउंड लिगामेंट था। तो विदाउट मेकिंग अनाउंसमेंट के वो तो राउंड लिगामेंट है। मैंने फिर ट्यूब उठाई उधर की, जब बांध रहा था तो मुझे एनेस्थेटिस्ट कहता है आई थिंक दिस पेशेंट हैज गॉट 3 ट्यूब्स। सो थिंग्स डू हैपन। लेकिन जो रुबीना ने टर्मिनल पार्ट में कहा कि आप सारा कुछ जो भी इन्होंने स्टेप्स बताए हर शय के बताए, उसको जस्ट गो ओवर इट अगेन, रीअसेस एंड इफ नेसेसरी रीडू। कोई हर्ज नहीं है, लेकिन रीअसेस कि आपने जो भी काम किया सही किया है। और मेरे नजदीक तो राउंड लिगामेंट और ट्यूब में फर्क यह है कि ट्यूब का लेटरल एंड फ्री होता है, राउंड लिगामेंट का फ्री नहीं होता। तो व्हेन यू टाई ट्यूब्स मेक श्योर उसकी लेटरल साइड पे वो फिम्ब्रियल एंड आपको नजर आ रहा है, देन यू कांट मेक मिस्टेक्स। लेकिन रुबीना ने एनाटॉमिकली उसकी लोकेशन सही बताई आपको, और थिंग्स हैपन।
थैंक यू।
मैं रुबीना ऑनेस्ट तुम्हारे लेक्चर से बहुत कुछ सीखा, मैंने सीखा।
आप ये शर्मिंदा कर रहे हैं।
नहीं, the way you have put all things there कि क्या क्या करना चाहिए क्या नहीं करना चाहिए, I hope all of them assimilate what you have said and they practice as well. क्योंकि पर्पस सिर्फ इम्तिहान पास करना नहीं है, पर्पस तो अच्छा गायनेकोलॉजिस्ट बनना है. With these,
Thank you.
मैं कहूँगा ये भी एक तबलीग है बाबा. इसका लिए इस्लाम की तबलीग अपनी जगह, अच्छा इंसान बनने की अपनी जगह, अच्छा गायनेकोलॉजिस्ट बनाने की ये जो कोशिश कर रहे हैं दोनों बैठे आपके सामने, ये अपनी जगह. We all thank them for their input and contribution in passing on good information to you. I hope you will practice it.
Thank you, sir.
वैसे
Just a
बात
small-
सुनो, ये दोनों मेरे शागिर्द हैं, मैंने सिखाया था इनको.
सिर्फ मैंने एक बात कहनी है, किसी ने लिखा हुआ है कि फिल्शी क्लिप के बाद यू नीड अ हिस्टोसल्पिंगोग्राम.
किताब में
दिस
लिखा,
इज रॉन्ग.
किताब
आप
में
जो बुक है उसका रेफरेंस दीजिएगा, क्योंकि फिल्शी क्लिप का फेलियर रेट इज ओनली 0.7%. So for a failure rate of 0.7%, I don't think you need to go back and do a histo. So ये आपका रेफरेंस जो है वो उसको अपडेट करने की जरूरत. चलो, थैंक यू.
अच्छा जी.